My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening, everyone. Welcome to tonight's BOFAS Lectures of Distinction series on Pilon fractures and circular frames. My name is Yasser Ghani, and I'll be your moderator tonight. Tonight's speaker is Nima Heidari, and thank you to Ramsay Healthcare for sponsoring our BOFAS Lectures of Distinction series. Now, thank you for, again, great feedback that we've been receiving so far, so keep your suggestions and feedback coming. As usual, some housekeeping. Any point, if you need to submit any questions, please use that in the Q&A section rather than the chat. And at the end of the lecture, then we can ask those questions. Your attendance certificate for CPD will be issued following submission of your feedback, and you'll receive an automated feedback email after logging out of tonight's broadcast. If you haven't, then we'll put in the chat the feedback code, and you can use the previous links and use that feedback code. So tonight, continuing on from last week's webinar on Pilon fractures, we're going to be taking it further and discussing about management with circular frames and principles of this. We have a fantastic speaker tonight, Nima Heidari, who's a good friend and mentor. He's the head of the Bone Infection and Limb Reconstruction Unit at the Royal London Hospital, which is one of the busiest trauma centres in Europe. He's a renowned teacher and educator and is actively involved in the education group for AO trauma. So without any further delay, over to Nima.
Great, Yasser, thank you so much. I'm going to start sharing my slides. Let me get myself all organized. Right, can you hear me and can you see my slides?
Yeah, that's great, Nima. Thank you.
Great stuff. Yasser, thank you so much for a very kind introduction, and my gratitude and thanks to the Education Committee at BOFAS who have asked me to come and talk about circular frames. I do a lot of foot and ankle surgery, but I do feel a little bit like an imposter because I do a lot of frames and a lot of limb reconstruction. But it's a genuine pleasure to be talking through the auspices of BOFAS. So before we start, some disclosures. I work with a number of companies, both through education, and I provide consultancy for devices, but nothing pertaining to this lecture. So tonight, what I'm going to talk about are really how and why we should use frames for distal tibial interarticular fractures. I'll talk a little bit about some of the literature that surrounds it. I talk about some of my personal indications and actually indications of our group at the Royal London Hospital, how I do the frames, how I put them on, and these will all be demonstrated through some of the cases that have come through our unit. And I have to say that some of them are not my cases, they are the cases of my friends and colleagues at the limb recon unit at the Royal London, without whom actually providing the service would not be possible. So a little bit around frames or fixation. There are a couple of papers from the early 2000s that talk about doing internal fixation and doing frames. Now, interestingly, the Harris paper, they have many more internal fixations of Pilon fractures. And what they found is that they had slightly more complications with frames, but there is a bit of a selection bias because one of the things that I see as a frame surgeon is it's too bad to be fixed, so why don't we give it to the frame surgeon to fix? And so there is some selection bias. Much the same happened in the earlier paper from Watson, but interestingly, there are high rates of non-union, malunions, and deep infections with the use of open reduction and internal fixation. There are a number of other papers as well. Generally, what you look at is that the majority of these papers are from 10 to 15 years ago. And the overriding thing is that many of them are around the use of external fixators, not necessarily circular frames. And actually, the mechanisms for fixing distal tibial intraarticular fractures using frames has evolved, and I will talk through some of those. And again, here we are staged, and the Obremski paper is actually the internal fixation within the spanning external fixator. But again, the differences at later on down the line at 1 and 2 years seem to dissipate. But the general overriding consensus from many of these studies is that you get less deep infection by treating these fractures using a circular frame. In order to answer the question of whether it is a good thing to use these circular frames for Pilon fractures, Hemant Sharma, our president at the BLRS, was instrumental in organizing this NIHR funded trial called the ACTIVE trial, which is to look at the type C Pilon fractures. I'm sure that Anand Pillai told you about these last time, but these are fractures that are what are described as complete articular, and patients who have closed distal tibial fractures are getting randomized to either being fixed with plates and screws or internal fixation. Some of them can be fixed with nails, and then to frames. And in time, I hope that in the next year or two, we can look back at this data and look to see whether we have an answer with regards to which of these methods is better. So then we go to the eminence part, eminence-based rather than evidence part of this talk, which is actually, well, what do I think as a frame surgeon and as someone who treats the complications of internal fixation, what are my go-to indications for these? So first thing is I do want to touch base on the staged protocol for management of Pilon fractures. This Sirkin paper from 1999 is an absolute classic. They demonstrated that in high energy distal tibial intra-articular fractures, the way forward is to span the joint using an external fixator, scan, and plan. That's where it all comes from. And by doing that, the soft tissue complications that we had in the 1980s and the early 1990s, where AO principles were being applied to the management of the Pilon fractures, dramatically reduced. So the staged protocol, it is really critical to know how to put on a good external fixator for the treatment of Pilon fractures. And in fact, in the first part of my talk, I'm going to give you a detailed synopsis of how we like to put these frames on, these spanning external fixators on in my unit. So here we are. Here is a typical example of a chap who has got an open Pilon fracture, okay? This is, I'm going to get my laser pointer. Look, you can see that there is a little thing here. This is maybe a grade 1 or a 2. We've managed to close it immediately after the initial debridement, and he's got a spanning external fixator on, right? Several important things. First of all, it is outside the zone of injury, and we can see that the zone of injury is denoted by this black circle. We also like to put the external fixator pins outside of where we feel the zone of surgery might be in the near future. So if you want to fix things with plates and screws, you want your external fixator pins out of this zone, because there are case series that have demonstrated increased risk of infection when you overlap your pin sites with where you put your plates. The next thing is you've got to protect the heel. You've got to take the heel off the bed. It's very quick and rapid for these patients to develop ulcers on the heel because they're obligated to bear load on the apex of the back of the heel, because your pin, your Denon pin across the calc here does not allow them to rotate and take the weight off it. The next thing is that I like a half pin into the first metatarsal. And the purpose of this is to ensure that you don't get a midfoot break. What you find is that if the patient is in this external fixator for a prolonged period of time and they're not bearing load, the ankle, so the hind foot and the talus may well be in a good position and aligned appropriately with the tibia. But then what you will find is that you will get a midfoot break, and you get a plantaris, you get flexion through the midfoot. So they develop a high arch and they get contractures in their foot. So in order to mitigate that, I like the first metatarsal half pin in as well. So step by step, how do I put on an X-fix? So the first thing is here you can see an incision with a 15 blade, directly where I want to put my first half pin, which is in the proximal tibia. I use a mosquito forceps, and this is done very gently. Don't stretch the skin of this incision. I then use a drill, even with half pins that are designed to be self-drilling and self-tapping. I always think that it is important to be gentle with traumatized bone. So I always do a pilot drill. This can be anything up to a 3.8, a 4mm drill, because you put 5mm half pins in the proximal, 5 or 6mm half pins. So I use the self-drilling and self-tapping half pins, but I pre-drill. So I will pre-drill, and this is the direction that I want to go. It is at the apex of the tibia, and it is aimed from anterior to posterior directly. I then irrigate the pin site, particularly taking the swarf and the debris from the drilling out from the soft tissues, and then I put the half pin in. I've put it in on power here, but I tend to torture my poor registrars with having to put these under hand. And the reason is that you get the feel of when you go through the far cortex, and that's quite important because you don't want to over penetrate on the other side. All external fixators now come with clamps that allow you to put 2 half pins. And here is one from the Synthes system, the Synthes monolateral external fixator. And this actually allows you to then get a guide, an appropriate guide for exactly for where your second half pin can go. And again, we repeat exactly the same, and we use the jig to allow us to drill a parallel half pin. The only thing that I would say is that here, what you're doing is that you're drilling on an oblique face running away from you. So this is a little bit more nuanced, and there are techniques to make sure that you don't slip down here. And I can maybe answer those in some of the questions if people are interested. Again, irrigate, put the half pin in, and now we start looking at putting the calcaneal pin in. So I span the ankle joint. I tend not to go into the neck of the talus. I don't like putting half pins into the talus. It is a rather delicate bone, and as for an ankle surgeons, we all love it. So please don't put half pins into the neck of the talus unless there is genuinely no other place to put it. Here, what you can see is I have marked out the lateral malleolus, the tip of the fibula, and the tip of the heel. You draw a line, you divide it into thirds, and actually this most distal third is where the safe zone is for inserting your half pin. You can also do the same on the medial side, and it's between the medial malleolus and the tip of the heel. But I usually put them in from the lateral side, and I'll tell you the things that you need to look out for. So why is that? In this lovely paper from Kwon et al., you can see this is the neurovascular bundle posteriorly. They have dissected it out, and they found that in their set of cadavers, 3.1 centimeters from the tip of the heel. And one of the other things that they did is that they placed these wires along the path of the nerves, and they x-rayed it so that it allows us to see where it is that the safe zone is going to be. And what they describe it as is, this 3.1 centimeter radius circle, and they suggest midway through that, which is pretty much around where the thirds is. Now, what you can see is that the tip of this, I've sort of fudged it in between the medial malleolus and the lateral malleolus, just to say that you just need to be in the safe zone here. Then I do two things. First of all, I make sure that the foot is absolutely vertical. And if you draw a line from the second toe to the middle of the heel, you want that line to be absolutely vertical. The next thing that you do is that you can see that hand, it gives me a guide to the direction of my half pin. And the way that I think about this is that you've got to make everything into right angles in the operating theatre, because you can judge right angles very well. So I put my hand parallel with the hand of my assistant who is holding the foot, and I make sure that I'm parallel to the floor because that is vertical. And then if you can drill in a straight line, then you come out on the medial side well away from the neurovascular bundle. If you feel that you may not be able to do this comfortably, then you can actually go from the medial side to the lateral side. I then put a pin into the first metatarsal, then you start constructing the external fixator. I like using these clamps and the bar. It allows you to make your initial A-frame. Before tightening these, you get someone to hold on to the Denon pin and pull, put traction on this. And on the II, you make sure that everything is lined up. You tighten these parts up. Then you put a crossbar between the two long bars and then attach the first metatarsal, making sure that you bring the foot into a neutral position. In our unit, we like putting these stirrups on in order to elevate the heel off the bed. There we are, and this is looking at it sideways. So this, for me, is an appropriate external fixator. It's well away from the zone of injury and future surgery, and it is a very stable construct, and it protects the heel. So now let's think about some of the reasons for definitive management of pilon fractures using a circular frame. And for me, really, the primary indication for this really is the soft tissues. Even in closed pilon fractures, not all of them are necessarily equal. Here we are. You can see that the skin is blistered, it is battered and bruised. In fact, particularly in this one, it may be that this is going to turn into full thickness skin loss. Here, certainly again, loss of the superficial layers of the skin. So you can see that these soft tissue injuries, despite the fact that these are closed injuries, still make you think twice as a surgeon about incising these soft tissues and placing metalwork inside. So for the first vignette and case, we have a 50-year-old female. She tripped down a number of stairs, very low energy injury, but this still ended up with a rather low spiral fracture of the distal tibia with a posterior malleolar involvement. So maybe this is an overestimation of the intra-articular nature of this fracture, but this is still, even if you were to fix this internally, this is not necessarily a simple and easy fracture to fix, either for nailing or with plating. She comes in, and this is, after putting an external fixator on, this is a week down the line from the original injury. And you can see that she has got circumferential blistering. There are still areas of the skin which seem to be non-blanching. These areas here, you can see as the blisters more proximally have come off, there is that punctate appearance of the capillaries slowly providing a blood supply for the dermis and the epidermis. But this is, you can see that despite the fact that this is low energy, this lady's leg has been wrung like a towel, and she has got degloving of the soft tissues around her ankle. This is it at day 14. I would still not be particularly happy at all to even put an intramedullary nail and put incisions around the medial side here for the locking screws. So we discussed things with her, and we put her into an external fixator. You can see that she has got this on now, and she was able to walk on this immediately. Look, even at some almost 3 months down the line, 10 weeks down the line, you can still see that the soft tissues around the distal tibia are not hospitable to incisions and internal fixation. And here it is, 5 months after the operation, she has got union of her distal tibia, and actually the alignment, which is one of the things that we worry about in this particular case, seems to be very well maintained. The other group of individuals that I like to think about is when you've got a great deal of metaphyseal comminution. We know that the metaphysis always, the metaphysio-diaphyseal junction heals much more slowly than the articular block. And this is a reason for non-union in many of these injuries. It's very rare to get non-union of the metaphyseal block and the articular block, but you can do so in the metaphysio-diaphyseal junction. For our next case, this is an 80-year-old chap. This poor man was actually, his foot was run over by an ambulance. So this is a relatively high energy injury. And what you can see is that he also has foot fractures. So this is a devastating injury for this guy's foot and distal tibia. And of course, the metaphysio-diaphyseal comminution. The soft tissues in this guy are absolutely not hospitable for 2 reasons. One is his age, he's 80, and the other one is the fact that he's had a rollover injury, and these are devastating torsional injuries, and you can get degloving, you can get quite a lot of degloving in these circumstances. And one thing I've said there is that as well as there being indications for why we use external fixators in particular fracture patterns and particular fracture types, one thing you've got to remember is that there is a patient which is attached to the fracture, and we do need to consider the factors, the host factors, in deciding what treatment protocol we use. So what are the options? Do we fix it internally? And in fact, one of the things that we need to consider is also amputation. The thing about amputation is that it is a good reconstructive operation. Unfortunately, I end up doing it many times, but the thing that we have to remember is that someone who is 80, having a below-knee amputation will obligate them to wheelchair use, and they will go on to have a lot of morbidity associated with that. So actually, the almost best scenario and solution is to do something for the patient to keep their foot, even if it's not going to be perfect. And what we did here is that he has, you can see that he has the articular block fixed with wires. These have been spanned to the proximal tibia. And in fact, the foot was also included with the fractures in this frame. What this allows for is that, look, this is the chap on day 2. Because of the robustness of the frame for allowing load bearing, he's able to actually get out of the chair and use his leg to transfer almost immediately after the operation. For rehabilitation, this is a profoundly positive experience for the patient. But this is not quite the end of the story. At 5 months down the line, what we've got is that the articular block has healed very nicely. You can still see some of the wires that are going through his foot, so we're still holding his foot out to length. But unfortunately, there is no signs of healing around the metaphysio-diaphyseal junction. So, is this a delayed union? Is this a non-union? This chap is slowly having enough of the frame on for a few months. So one of the things that we did here was to take him to the operating theatre, remove a segment of the fibula to allow compression at the non-union site. And this is a very powerful way of helping the healing around the distal tibia. This goes on to heal, and at 8 months post-operatively, he has relatively good alignment. The ankle joint itself, you can see from here, has not really, this is not great, but he's in his 80s, he's kept his own foot, he's ambulating on it, there is no infection, there is robust soft tissue envelope, and the bones have gone on to unite, which I think is a relatively good result for this patient. The third the indication that that comes to mind for me personally, again, is the unreconstructable joint. There are circumstances where either the joint is very comminuted, or it's a combination of comminution and soft tissue injury, where you think about just essentially spanning the ankle, not putting internal metalwork in, to allow options for later reconstruction. Now, here is a 42-year-old man. He was snowboarding abroad. He had a terrible injury. He had an external fixator applied abroad, and he came back to the UK. Unfortunately, for one reason or another, there was a huge delay to him presenting to my clinic. So it took him 8 weeks to come for definitive treatment. Now, at 8 weeks down the line, what are the options that we can use? Can we go back in, open everything up, and attempt internal fixation? Well, one of the things is that the metaphyseal block has partially united. It's almost fully united. And also you can see that it is malunited. The joint is absolutely destroyed. But one of the things here is that the subtalar joint is very well maintained and very well preserved. So I had a long discussion with this chap, and we decided for an acute fusion of his ankle. So arthroscopic preparation of the talar dome, which was already in very poor shape. Unfortunately, I don't have the arthroscopic pictures of this, but he had several huge gouges in the articular surface of the talus. So arthroscopically, we prepared the surfaces. And what I would say is that in my opinion, when you're wanting to perform acute fusion of pilon fractures, it is better to wait for a period of time, if that is an option which is available to you, to allow consolidation of the metaphyseal block before you prepare the joint arthroscopically. So having prepared this joint arthroscopically, I then compressed the articular segment and then compressed at the metaphysio-diaphyseal junction, and a few months down the line, he has actually fused the ankle joint, the subtalar joint is well maintained, and he's back cycling. So it is a consideration to think about the unreconstructable joint as one of the other options for treating them with a frame. If I had not fused his ankle, I would have probably just spanned him. I would have distracted the ankle joint. I would have allowed him to start bearing load on it. And that allows us to then later on perform ankle fusion in the absence of metalwork. In circumstances where you think that the ankle fusion is going to be very likely, and we know that one of the main determinants of that is damage to the articular surface of the talus. In those circumstances, if you have a lot of metalwork to contend with, taking out posterior plates, taking out anterior plates, and so on, it makes for rather challenging surgery and not necessarily pleasant for the patient's soft tissues. So in those circumstances, again, I prefer to use a frame to allow the possibility of either replacing the ankle or fusing the ankle at a later date in otherwise relatively virgin soft tissues. So now some guidance from, for how to think about putting a frame on. Now, this is a lovely paper from the guys that trained me how to do frames. Mike Whitehouse is actually a professor in Bristol now, and James Livingston, who's a superb foot and ankle surgeon, is doing less frames now, which I think is a bit of a pity, but there we are. But what they've taught me to do is use a very large half frame. So these are, you can see, very large rings. You then put one wire in the proximal tibia, one wire in the calcaneum. So this provides intraoperative traction, which allows for the fixation of the articular block. And then you can build a frame within a frame. So the entirety of this frame is actually built inside this large half frame with the patient in traction. Now, I also use a similar sort of a device for performing tibial nailing. So for doing intraoperative traction using fine wires, this is a very, very nice trick. So this is just the setup. The patient, you can see, is supine. The limb is prepped and draped below the knee. I don't use a tourniquet for trauma. We can use intraoperative traction. The next thing is that, much like any surgery for periarticular fractures, reduction of the articular surface is really critical. And the ankle joint is incredibly sensitive to malreduction. So we can and we should perform reduction of the articular surface in the acute phase. Here we can see that there is an intra-articular fracture of the distal tibia. In fact, this patient was part of the active trial, and he was randomized for an external fixator. For this, you can see I find the axials at the level of the plafond very useful, because it allows us to see the pattern of the intra-articular fracture. We can also then use the sagittals and the coronals to look at the metaphysio-diaphyseal section of this fracture. So the way that I plan this is on the axial. This is the tib and tendon. This is the EHL and EDL and the neurovascular bundle on this side. And the way that I want to approach this fracture is actually through here. So you can do a direct approach into the fracture to clear out some of the debris here and to put the articular block back together. I use very low screws. So you can see that the articular reduction, there is a gap there, but it is very well aligned. So to go back, one screw is from front to back to hold these together, and another screw is to hold the medial malleolus to the rest of the articular segment, which is what you can see here. Then, and these can be done through relatively small incisions, then we put a frame on. So you can see on the lateral, this leg is still in traction. That's why you can see the talus is translated anteriorly. So you can see that the AP screw, the medial to lateral screw, the joint has been reconstructed, and then the metaphysio-diaphyseal segment is neutralized with a frame. These are some CT scans at a few weeks down the line, sort of a couple of months down the line, actually. I use CT scans liberally, particularly when I'm deciding when to take the frame off to look at the healing of the metaphysio-diaphyseal junction. You can see that it's got some way to go. The fibula has healed. And again, you can see that the articular block here has actually healed very nicely already, which is in line with what we expect. And you can see that the CT scan was a little while ago, and he's now coming up he's very close to having the frame removed, because you can see the presence of the callus around this metaphysio-diaphyseal junction. Now, one of the things that we are used to hearing is about the safe corridors for placement of wires. And I wanted to show you some of the safe corridors and the structures that are at risk. The two pictures that you can see are cross sections of the distal tibia just above the plafond and at the level of the plafond. Some neurovascular structures that you need to be cognizant of is the posteromedial neurovascular structures and the anterior neurovascular structures. There are also some cutaneous nerve, the superficial peroneal nerve, which sits here, and the sural nerve, which is at the back here. So when you look at the distal tibia, this is how it fits inside the ring. So this is a ring from the talar-spatial frame from the TSF. There are other frames on the market as well now. The Stryker make their own frame. There's the Orthofix frame. Johnson & Johnson have got a frame. So my talk is very much based around the talar-spatial frame, because that is the frame that we've all grown up with, but there are other options that are coming through now. So here you can see the distal tibia. You can see this is where the frame will sit. And usually we start off with something called the reference wire. The reference wire is just anterior to the fibula. It goes across the tibial plafond, and it is usually around the mid-zone of the tibia. You can see that there are no particular structures that are at risk here, and this allows us to mount the ring on the distal tibia. Other wires that you can put another parallel wire, and in fact you can put it posteriorly as well, because you can see that you can go through the fibula and the posterior aspect of the tibial plafond. Where exactly you place these wires is partly dependent on the fracture and partly dependent on the soft tissues and the patient's body habitus. So these can be migrated anteriorly or posteriorly. There is a transfibular wire in order to maintain the syndesmosis, and also an anterolateral to posteromedial wire. There is also the possibility of doing a posterolateral wire, and this sometimes you can put as an olived wire, which is a bleb on the wire here, to try and pull in the posterior malleolus. Now, one of the things that you can see here is and what we talk about is the crossing angle of these wires. And I'm going to show you why having a wide crossing angle, so having a crossing angle of 90 degrees between the components of the frame with these tensioned wires, is really quite critical. So here we have, this is an axial view of a bone and the frame. So you can see that if you have got wires crossing at 90 degrees, these are not going to slide anteriorly and posteriorly or medially and laterally on the bone. As the crossing angle reduces, you can see that there is more and more scope for the ring to slide on the bone that it's trying to fix, so that with parallel wires, it actually slides quite a lot. The other thing is that if you turn this on its side, you can see that the bending moment also increases as you have your wires parallel. So if you've got these wires there, in this plane here, the ring can rotate around those wires. Whereas if you've got crossing angle of 90 degrees, it does not rotate. So in order to exert control over the bone segment that you've mounted your ring on, it's critical that your wires have a good crossing angle. And here we are. This is demonstrated quite nicely. This is again a distal tibial fracture, open fracture. And look, you can see that this wire, this one, and the AP half pin give us a really good control over this segment. And you can see some of the wires are above the ring and some of them are below the ring. Another thing that we think about, particularly with hexapod frames, is that the struts also want to be attached to the ring at specific places. With more modern software and devices, the need for thinking about this has reduced because you can move around them. So for example, you can see that this wire and this wire will stop us putting our hexapod on our struts, mounting our struts on these areas. But now with the software, we can move them to elsewhere. But one of the other ways to also both extend your fixation is to use a slave ring. So actually what we do is that this is our fixation ring. We then add another ring, which allows us purely just to add the hexapod. And here is another example. In this case, you can see that actually I've turned the hexapod upside down to allow for the fixation of all of the wires onto this ring. Another thing that I want to talk about is something to be aware of is the ankle joint capsule. The ankle joint capsule is far more proximal than sometimes we think, particularly anteriorly. You can see that this is a very nice diagrammatic representation. The capsule comes some way down the neck of the talus, and also it comes a little bit up on the plafond. Also, the incisura and the syndesmosis is a synovial joint. A very nice paper from Stephen Haddad and his group, which shows that the various amount by which the capsule reflects on the tibia, and it can be up to quite a long way, up to 1.5 centimeters, 12 millimeters anterolaterally. But to be honest with you, one of the things that I would say is that the risks of developing infection with these deep infections are very, very low. And sometimes the necessity for fixation of the fracture stumps and actually trumps, in a way, the placement of the wires. So I do go very low on the wires, but then you have to have meticulous pin site care to try and mitigate those issues. So in summary, the things that I think about when it comes to fixing distal tibial fractures using external fixators. One of them is the temporary stabilization. And I hope that you now have a very good idea of some of the things that you need to be able to perform a good external fixator, spanning external fixator. For the definitive treatment of distal tibial fractures using circular frames, soft tissues. Soft tissues are incredibly precious around the distal tibia, and they are fickle. They fail readily, and replacing them is not so easy. So trying to preserve them as much as possible, not just for the fracture fixation, but actually some of the issues that come about as a result of the trauma is critical. Metaphyseal comminution and bone loss that's what the frame is actually designed for, to be able to treat non-unions and to be able to deal with bone loss. So it is a good option to have. And also think about it when the joint is unreconstructable, and you know that the fixation of this fracture is the first step in quite a long journey that these patients with Pilon fractures tend to have. So that brings me to a close, and this is a lovely view from the Royal London building looking across the city. And I have to thank my colleagues at the Royal London for providing some of the slides and some of the fantastic cases that represent some of the concepts that I'd hope to be able to share with you. So thank you very much. I'm going to stop sharing my screen now so that we can attend to some of the questions that may have come up.
Thank you, Nima. That was a great session. So I know you have a case to discuss as well, but we'll take some questions before, and if we have time, then we'll go to the case. So one of the questions from Alvin from Leicester is, hi Nima, curious to know, when do you span the joint and when you do not? As you showed with the older patient, it seems to help with the early full weight bearing. So do you have any preference?
Yeah, so that's a great question. One of the things is that I started out not spanning the joint very often at all, and I've gone more and more towards spanning the joint. I tend to span the joint for the first 6 weeks or so. That's almost in all of the patients who have a lot of intra-articular comminution. This allows me to distract the joint. It also allows the patient to bear load. It stops the patients going into equinus, because we know, we don't really like allowing patients to bear load on intra-articular injuries for a period of time. And if they can't, they drop into equinus really quite readily. So I've gone to spanning the foot a lot. The other thing I found is that if you span the foot, the pin sites around the distal tibia then have a little bit of time to settle, and they don't get so irritated so quickly at the beginning when the frame has just gone on. So in a way, it is always a good option. If the foot is injured, so if you've got foot fractures, absolutely span the foot. Otherwise, I would consider it, particularly if the ankle is unstable, and I think that the patient is going to be non-load bearing for a period of time to help mitigate equinus.
Okay, great, thank you. Another thing about we come across, even in FRCS topic, you've got an infected Pilon fracture with metawork in situ. When would you consider putting a circular frame on those? And is that an option sort of thing for?
Absolutely. So that's a great question, actually. So look, one of the devastating complications of Pilon fracture fixation is deep infection. How do we deal with deep infection? Well, the principles of it is that you have to make a diagnosis first. And also to try and decide whether it is a failure of fixation as well as infection, and whether there is a failure of soft tissues. If there is any failure of the soft tissues and you are not certain about the fracture having united, I think that you have to consider referral to a specialist unit, because this is now an orthoplastics problem. Mm-hmm. When do I use circular frames? Well, if it has not united. So if you've got a distal tibial fracture where it is not united, and you take all of the metal work out, and there is a bone loss and you've got a non-union, I would then span it. I would make sure that we have got intrafocal antibiotics, so we're managing the dead space. We collaborate with the plastic surgeons to make sure that the soft tissue envelope is robust. And then we start thinking about how we're going to reconstruct the bone.
Okay, great. Now, another question, and that's about, so we're seeing, you probably see them quite often at the trauma center, high energy fractures, Pilon fractures, but also ipsilateral calcaneal fractures. Mm-hmm. Now, do frames come into play in fixation of both if you have a Pilon and an ipsilateral calcaneal that could benefit them from some sort of management? How would you do that?
Absolutely. So look, the first thing that I would say is that ipsilateral calc and Pilon fractures is a devastating injury, right? It's a very, very high energy injury. They're very difficult to manage. My initial go-to is that we need to think about the calcaneal fracture. You can even fix the calcaneal fracture with a number of wires to reduce the posterior facet. And put the calcaneal tuberosity in the right place in relation to the talus and the shaft of the tibia, and then you can treat the tibial fracture on its own merit. And I would include the foot in these fractures as well. I've had a number of them, not very many. The thing to say is that you can absolutely do it, and I would go to a frame, because the soft tissue insult required for internal fixation of both of these is quite a lot. The patients are never happy, because that degree of injury with the soft tissues, the foot is stiff, the foot is painful. You lose a lot of the pad of the heel. They get fat necrosis of the heel pad. So despite the fact that the soft tissue may be robust, you get a very thin heel pad from these, because it's, it has been squashed by the ferocity of the injury. So I think, again, the principles are, what is it that you can do to restore the shape and the alignment of the hind foot and of the tibia, and do so with the least insult to the soft tissues?
Okay, I fully agree. I think it is devastating injury, isn't it? And we see them at, I remember when we were at the Royal London, seeing all of these. You also mentioned about fragility fractures, and we are seeing, and this is a very complex, I find them quite complex, 80-year-old, 85-year-old with, or diabetic comorbidities. What do you do, with these Pilon fractures? They've had these. There are, some people argue about not doing anything about internal fixation. Some might say even hindfoot nails in these, a specialized group. You've treated this sort of thing with frames. What's your thoughts on it, and what's your experience in patients actually coping with a frame with this?
So there are positives and negatives for frames and for internal fixation in this group. One of the problems with fragility fractures is that the rather fragile bone is covered with rather fragile soft tissues. Yeah. Nailing, I think, is a good option for these. So hindfoot nails in highly comminuted fractures. The other thing that can be done is a spanning circular frame to allow the articular block to start healing, and then doing an acute fusion. The osteoporotic bone can be treated very well with a circular frame, and they can bear load immediately. So that's something that they can do almost immediately. The problem is, though, that they are very, very difficult patients to manage, particularly on the nursing side. So I'm really lucky, because we've got a specialist frame nurse, and we now have a specialist physio who has a particular interest in frames. So between the two of them, they're amazing. They really field a lot of their questions and problems with these patients. So it goes back to what I was saying, is that you can't forget the host. And it's not just the frame. Managing these patients, almost irrelevant of the fracture fixation method, is a genuine challenge. Now, the diabetics is another one that you mentioned. The thing with diabetes is that we have to be quite careful. Neuropathic patients and frames are, again, quite a difficult bunch. They don't have the protective sensation of pain, so they will walk on the frame, they will break lots of wires, they will develop pin site infections, particularly around the distal tibia and the foot. So they have their own challenges. So I think diabetics are a slightly different beast, and you have to decide, is this a normal fracture pattern in a patient who has diabetes, or is this an injury and distortion in the bone that we can see because of the diabetes? Because those two are very, very different beasts, so they have a very different approach.
Okay, that's great, thanks. Another question has come in. What are the characteristics of Pilon fracture which will make you think of ankle fusion in the first go?
Okay, so one is very severe comminution, and sometimes you can see that even part of the talus, you can see the gouges in the talus on the CT scan. It's a conversation to be had with the patient. If the patient is young, what is young? It's the older I get, that changes dramatically. So the thing is that it's a conversation with the patient. So in the very acute situation, I think that, you know, we have to see. So for example, an open fracture when you've got exposed cartilage, where you've got huge contamination, then you can think about doing a fusion at the same time. If you have got, much like my chap, where you have a delayed presentation, so they come with an absolutely destroyed distal tibia, and it's several weeks, it's 6-8 weeks down the line, it's impossible to unpick that. So again, you know, what do? You curtail their treatment cycle by trying to fuse the ankle. So there is no absolute indications, and there's no dramatic contraindications. It requires, it's a tool that you have to have in your box, and it's a detailed conversation that you need to have with your patient. And also, you know, one thing that I have to come back to is that I work with two amazing guys, and I discuss loads of cases with them. That's just on limb recon side. I also have 3 amazing foot and ankle colleagues. And again, I talk to them about these as well. So actually, you know, it is a bit of a communal decision. But what is the exam answer? The exam answer is a joint which is unreconstructable in an appropriately consented patient who understands the consequences.
That's fantastic. I think we'll stop there with the questions, Nima. Thank you very much for a brilliant session on circular frames and Pilon fracture. And, you know, I think this lecture will serve as a great reference. It will be available on BOFAS YouTube channel to watch later on. So thank you again. Thank you to Ramsay Healthcare for sponsoring the series again. Reminder that you will receive the attendance certificates for CPD following submission of your feedback. And if you haven't, then use the code from tonight that we've put in the chat. Now, we'll be taking a break, a Christmas break, and we will come back in January. And the first lecture back will be on the first Wednesday, 5th of January, another important FRCS topic, which is Lisfranc injuries by Adrian Hughes. So have a good night and a lovely Christmas from everybody at the BOFAS Lectures of Distinction team. Thank you very much.
My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.